Good day, Philippines. I am Dr. Edgar Von Bravo, and this is DEN TV. For our headlines,
Behcet disease and burning mouth syndrome outbreak in Mindanao. Mouth-watering delicacies of Laguna.
today our dental heroes are conducting a dental mission in one of the underprivileged places here in the Philippines, where our dentist journalists found that most of the children, 4 to 8 years of age, are experiencing Behcet disease and burning mouth syndrome. For further information, let's hear the details from our reporters on site, Doc Brian Evangelista and Doc Vian Calliope, live in Seoul, Sultan Kudarat.
Yes, Doc Edgar, good morning.
Hello, Doc Edgar. Good morning. As you all know, oral mucosa lines the oral cavity, and it is continuous with the skin of the lip with a vermilion border and with the mucosa of pharynx posterior. According to one of our missionary dentists here in Sultan Kudarat, oral mucosa can be classified into three distinct regions: the masticatory mucosa that comprises of the gingiva and hard palate, the lining mucosa that comprises of the lips and cheeks, and all other regions except the dorsum of the tongue.
Because the anterior two-thirds of the dorsum of the tongue is already known as the specialized mucosa. And the specialized mucosa is the dorsolingual mucosa that has numerous papillae in the anterior part that contains the taste buds, which helps in the perception of taste. While papillae are the epithelial projections with the core of connective tissue, and our filiform is the one that has the most numerous papillae and are long thread-like structures with a highly keratinized epithelium but does not contain taste buds.
And aside from this, our missionary dentist also emphasized the importance of oral mucosa in our interview by stating that oral mucosa protects the underlying tissues from mechanical forces resulting from mastication and from abrasive nature of foodstuffs, lubricates the mucosa for swallowing its speech function, defends against the entry of bacteria and their toxins, and is sensitive to touch, pressure, pain, and temperature.
Indeed, the answers of our missionary dentist are very informative for our viewers. But can you give us other details about the structure of the oral mucosa, Doc Brian Evangelista?
Yes, our missionary dentist will give us information about the structure of oral mucosa so that we will not only understand what is the cause and the treatment that can be done, but also to better understand the importance of our oral mucosa. As what the missionary dentist that we interviewed said, there are two layers of oral mucosa that is said to be the stratified squamous epithelium that is separated from the lamina propria by the basement membrane. And ultrastructurally, this interface is called basal lamina that consists of a clear lamina lucida and a dense lamina densa. Lamina lucida is a glycoprotein layer containing collagen fibrils type 4 and is immediately subjacent to the epithelium and the connective tissue called lamina propria. This lamina propria consists of a papillary layer which occupies the space between the epithelial projection that is known as the epithelial ridges and a reticular below it. This papillary layer depends upon the length of a epithelial ridges and it can be even absent in the alveolar mucosa. This lamina propria contains types 1 and 2 collagen fibers and elastic fibers in lining mucosa which helps to restore tissue after stretching. The mucosa is attached to the underlying structure which is either bone or muscle by a loose connective tissue called the submucosa. The submucosa consists of connective tissue with larger blood vessels, adipose tissue, and minor salivary glands. The submucosa is not well developed in the masticatory mucosa, therefore adipose tissue and minor salivary glands may be absent in this region. For our audience, including us to not be confused, our missionary dentist added the masticatory mucosa is different by lining mucosa in a way that the masticatory mucosa is tightly bound to the bone while the lining mucosa is loosely attached to muscle to allow distension. The epithelium is keratinized, the lamina propria is dense, and the submucosa is thin in masticatory mucosa, while in lining mucosa, the epithelium is non-keratinized. Lamina propria is not dense and submucosa is prominent. And that our skin is always different with oral mucosa by means that the epithelium of skin is always orthokeratinized and contains appendages like hair follicles, sweat glands, and sebaceous glands.
What are the cells of the epithelium that are keratinized and non-keratinized, Doc B and Calliope?
The keratinocytes are the ones that have cytokeratin filaments.
And these keratinocytes, according to our missionary dentist, are arranged in different layers, undergo mitotic division, ascend or move towards the surface, also show changes in their morphology, structure, and in their function. These changes are known as differentiation, and their ascent or cell migration is called maturation. The time taken for a cell to divide and pass through the interepithelium is called turnover time. Once a cell reaches the surface, it gets shed. This process is called desquamation. While the non-keratinocytes are the ones without cytokeratin filaments, and these non-keratinocytes do not show any of these changes, such as no mitosis, maturation, differentiation, or desquamation. The cells are present in much fewer numbers and have varied functions. Melanocytes are the ones present among the basal cells which produces melanin pigment and transfers it to the adjacent keratinocytes through their dendritic process, and these melanocytes, as stated during the interview, can be studied using Doppler reaction or silver stains. Also, through melanocytes that vary in number that it makes the gingiva highly pigmented, Langerhans cells that are present in the spinous layers of keratinized mucosa that functions in picking up the antigens and present it to the macrophages, and Merkel cells that is found among the basal cells in the keratinized mucosa. The three melanocytes, Langerhans cells, and Merkel cells are the non-keratinocytes. The non-keratinocytes do not stain with routine H&E stains and therefore are referred to as clear cells. They are also known as dendritic cells because they show dendritic processes.
How are these cell layers arranged in the epithelium, Doc Brian Evangelista? Will you tell us how they are structured?
As said by the missionary dentist, the keratinocytes are arranged in 4 layers in the masticatory mucosa, which are the stratum basal, stratum spinosum, stratum granulosum, and stratum corneum. The basal cells are a single layer of cuboidal cells which rest on the basement membrane, show mitotic activity and protein synthesis. Ultrastructurally, they may show serrations and get attached to basement membrane by hemidesmosomes or be non-serrated so that they can undergo differentiation and migrate. Desmosomal junction exists between adjacent basal cells which contains protein of the cadherin family, while the stratum spinosum shows larger polyhedral cells which show intercellular bridges. Towards surface, the cell becomes flatter with fewer intercellular bridges. The cells synthesize proteins and contain bundles of tonofilaments, while the stratum granulosum contains cells which are flatter and wider than the spinous cell. Protein synthesis becomes diminished and the nuclei start to show signs of degeneration. Tonofilaments increase in number and are associated with the keratohyalin granules. The contents of the Odland bodies are discharged intercellularly to act as the permeability barrier. Involucrin protein thickens the inner cell membrane and helps in the cross-linking of tonofilaments. The stratum corneum contains flatter and wider cells with the dense bundles of tonofilaments aggregated by the filaggrin. In orthokeratinized epithelium, the cells show no organelles or nucleus, but in paraketinized epithelium, the cells show pinnotic nuclei and partially lens organelles. While the lining mucosa or non-keratinized epithelium contains three layers: the stratum basal, the stratum intermedium, and the stratum superficial. The basal cells are same, but the stratum intermedium, the polygonal cells, are larger, does not exhibit the prickly appearance, and show very less amount of tonofilaments, while the superficial layer contains wider and flatter cell having nucleus and organelles, but with few tonofilaments which are not tightly packed.
Thank you for that simple explanation to us, Doc Brian Evangelista. But I have a question for you, Doc Vian Calliope. I am curious as to what is the connection of the hard palate to the oral mucosa.
The connection between the two is that the hard palate mucosa is tightly bound to the walls and shows four zones: the gingival region adjacent to the gingiva, the median or palatine raphe area in the midline, the anterolateral or fatty zone, and the posterolateral or glandular zone.
Only the anterolateral and posterolateral zone contains the submucosa, which shows minor salivary glands in the posterolateral and adipose tissue in the anterolateral zones. Vestigial nasopalatine ducts, hyaline cartilage, and embryonic epithelial remnants in the form of epithelial pearls may be seen in the incisive papillae area.
Now let's go back to Doc Brian Evangelista. Doc Brian, can you also tell us something about the gingiva?
The attached gingiva, which is attached to the underlying bone tooth, shows a stippled surface and is demarcated from the free gingiva by the free gingival groove. The interdental papillae or the buccal and lingual side is connected by caul, which occupies the area below the contained point. The space between the inner aspect of the gingiva and the teeth which are present and all around the tooth is called gingival sulcus. Its normal depth is about 1.8 mm. The depth is measured by the probe as the distance between the crest of the free gingiva and the dentogingival junction. The free gingiva is the absent when there is no gingival sulcus. The epithelium of the gingiva is keratinized by the epithelium of the caul and the lining the sulcus. Sulcular epithelium is non-keratinized.
I have a question, Doc. What do you call that unique junction that is an attachment of an epithelium with hard tissue?
Doc Edgar, it is the dentogingival junction. The dentogingival junction is a unique junction because it is an attachment of an epithelium with a hard tissue. The attachment between the tooth and the epithelium is called the epithelial attachment. The outward flow of the gingival fluid, the lysosomal production, and the constant presence of defense cells ensure adequate defense against the bacterial invasion. The union between the tooth and the epithelium is called epithelial attachment. The internal basal lamina lacks laminin, ankyrin fibrils, and type 4 collagen. The position of dentogingival junction changes with time. The epithelium detaches from the crown, gradually exposing the more amount of crown, with the results of the bottom of gingival sulcus shifts apically. The physical integrity of the attachment is maintained at all times. Later, the reduced enamel epithelium gets gradually replaced by the growth of gingival epithelium, and this is known as the secondary attachment epithelium. When the tooth makes its appearance in the oral cavity, the reduced enamel epithelium is attached to the tooth, and this is referred to as a primary attachment epithelium.
Interesting. How about the structural variation in lining mucosa in different regions? How do they differ, Doc Vian?
The lining mucosa of different regions differ from one another in the thickness of their epithelium. The epithelium of the floor of the mouth is the thinnest, and those of buccal mucosa is the thickest.
The presence of elastic fibers in the lamina propria or soft palate, and in the thickness and content of submucosa, thin submucosa in inferior aspect of tongue, thickest with mixed glands in adipose tissue in labial and buccal mucosa, only mucous glands in soft palate, and few mixed glands in alveolar mucosa.
Doc Brian, how does the development of the oral mucosa occur?
The epithelium of the oral cavity is derived from both the ectoderm and the endoderm. The anterior part of the oral cavity is lined by the epithelium derived from the ectoderm. The vestibular lamina separates from the primary epithelial band at about 6 weeks. By the 13 to 20 weeks, differences between keratinized and non-keratinized mucosa becomes apparent. Lingual papillae appear early at about 7th week. The circumvallate and the foliate papillae appear earlier than the filiform papillae, which can be recognized by 10 to 12 weeks, and in the propria, reticular fibers are the first to appear within 6 to 8 weeks, followed by the collagen fibers, which is 8 to 12 weeks, and the elastic fibers appear much later by about 17 to 20 weeks.
Additional question, Doc. What age changes happen in the oral mucosa? Will you discuss it briefly?
With the age of the oral mucosa becomes smooth and dry. This is due to the reduction in the thickness of epithelial ridges and decrease in the salivary secretion. Varicose veins on the ventral aspect of the tongue are often seen. The effects include a progressive loss of sensitivity to thermal, chemical, and mechanical stimuli. These are due to epithelium becoming thin, mainly due to the reduction in the thickness of epithelial ridges and decrease in the salivary secretion.
Doc Bian, can you explain to us the causes and treatment of burning mouth syndrome and Behcet disease, which affected children's ages 4 to 8 years old?
I will start on discussing about the causes of burning mouth syndrome. The cause behind developing BMS is primarily due to a hormone imbalance, or more specifically, a drop in estrogen levels.
This hormone decrease can reduce saliva production, cause a metallic taste in the mouth, and trigger a burning sensation in the mouth. Some menopausal women also experience greater sensitivity to pain. Allergies or reaction to foods, food flavorings, other food additives, fragrances, dyes, or dental work substances. Reflux of stomach acid or gastroesophageal reflux disease or GERD that enters your mouth from your stomach. Certain medications, particularly high blood pressure medications. Regarding its treatment, burning mouth syndrome may last for months to years. In rare cases, symptoms may suddenly go away on their own or become less frequent. Some sensations may be temporarily relieved during eating or drinking. There's no known cure for primary burning mouth syndrome, and there's no one sure way to treat it. Solid research on the most effective method is lacking. Treatment depends on your particular symptoms and is aimed at controlling them. You may need to try several treatment methods before finding one or a combination that helps reduce your mouth discomfort. And it may take time for treatments to help manage symptoms. For secondary burning mouth syndrome, treatment depends on any underlying conditions that may be causing your mouth discomfort. For example, treating an oral infection or taking supplements for a vitamin deficiency may relieve your discomfort. That's why it is important to try to pinpoint the cause. Once any underlying causes are treated, your burning mouth syndrome symptoms should get better. Attached to the screen are some pictures of burning mouth syndrome.
Since we're done with burning mouth syndrome, this time I will be giving some information about the causes and treatments about Behcet's disease.
Behcet's disease is also called as Behcet's syndrome. It is a rare disorder that causes blood vessel inflammation throughout your body. This disease can lead to numerous signs and symptoms that can seem unrelated at first. They can include mouth sores, eye inflammation, skin rashes and lesions, and genital sores. Behcet's disease might be an autoimmune disorder, which means the body's immune system mistakenly attacks some of its own healthy cells. It's likely that genetic and environmental factors play a role. Treatment involves medication to reduce the signs and symptoms of Behçet's disease and to prevent serious complications such as blindness. There's no cure for Behçet's disease. If you have a mild form, your doctor might suggest medications to control the pain and inflammation of flares. You might not need medication between flares. So here are some pictures of Behçet's disease from the victims here in Sultan Kudarat.
Thank you for that report, Doc Brian Evangelista and Doc Bian Calliope. We hope that the outbreak will be resolved soon. Doc Kisha and Doc Kat went to Laguna to experience their tempting delicacies. But before that, we will have a short break with this advertisement from our sponsors.
Dent TV presents denttv.org, our very own website that contains many informational and instructional videos for your oral cavity. It's completely free. Just visit denttv.org and learn more about your teeth and oral cavity.
And we're back. Let's find out how Doc Kisha and Doc Kat ruined their diets.
Ever wondered how you're able to eat with just 20 pesos? A family in Cabuyao proved that it is possible as they started this new food challenge that is very popular today by saying, "Would you like to eat for only 20 pesos? So hold on to your seats as we travel to this city only in Laguna."
For only 20 pesos?
Really? You can get any food you want for only 20 pesos?
What? I know it's hard to believe, but let's start our 20 peso food hopping here at Cabuyao City. Salivating, right? But do you know that your saliva is secreted from salivary glands?
Yes, that's right. Salivary glands play an essential role in our body by virtue of their ability to secrete saliva. Saliva has a playful role in maintaining the health of the oral cavity and in carrying out physiological functions such as mastication, taste, perception, speech, and etc. Salivary glands are classified as exocrine glands, which means glands with a duct system to transport secretions from the gland. Salivary glands are tubuloacinar glands that indicates the presence of a branch duct system and secretes units with both tubular and acinar portions. Based on the method of secretion production, salivary glands are merocrine glands. The term merocrine is derived from the Greek word meros, meaning part, and krino, meaning to separate, which literally translate to partially secreting. However, this is not completely correct. The secretions of the salivary glands are secreted through a process of fusion of membranous secretory recycle termed as granules with the apical plasma membrane, and this process is known as exocytosis.
Salivary glands are broadly divided into major and minor salivary glands. The major salivary glands produce about 0.5 to 0.75 ml of saliva on a daily basis. There are three main types of major salivary glands. These are present in pairs, and these are the parotid gland, the submandibular gland, which was formerly known as the submaxillary, and sublingual glands. The parotid gland is the largest major salivary gland. It is purely serous in nature for adults, whereas in newborns, it is predominantly serous. Submandibular glands are intermediate-sized major salivary glands, and they are predominantly serous. Sublingual glands are the smallest of the three major salivary glands, and it is predominantly mucus-producing. The minor salivary glands are located in the submucosa of different parts of oral cavity, which include the lingual salivary glands, which are termed as one-embossed gland, labial, buccal, and palatine glands. Among the minor salivary glands, the lingual salivary glands start as the von Ebner's gland are the only one which are serous. The palatine and the buccal glands are mucus-producing, whereas the rest of the glands that have the labial glands, these produce mixed secretion of saliva. The parotid submandibular and sublingual salivary glands contribute to 90% of total saliva secretions, while minor salivary glands contribute to the remaining 10%.
Looking at the anatomical aspect, the parotid gland is located subcutaneously below and in front of the ear in the space between the ramus of the mandible and the styloid process of the temporal bone. The submandibular gland is located under the floor of the mouth in the submandibular triangle of the neck. And the sublingual gland is located in the floor of the mouth anterior to the submandibular gland.
The salivary gland secretes saliva into the oral cavity through ducts. The different ducts of the salivary glands are the Stenson's duct, which is a duct corresponding to the parotid gland. It extends from the lateral surface of the gland anteriorly, then moves across the masseter muscle and pierces the buccal fat of the pad. And the vaccinator muscle opens into the oral cavity in a papilla opposite the crown of the second maxillary molar tooth. The submandibular gland is located medially to and under the partial cover of the mandible. The duct of the submandibular gland, that is Wharton's duct. It extends anteriorly to the floor of the mouth and opens in the oral cavity at the sublingual papilla, which is present at the site of the frenulum of the tongue. The sublingual gland is located beneath the mucous membrane of the floor of the mouth. The main excretory duct of the sublingual gland, which is Bartholin's duct, may join the submandibular duct, that is Wharton's duct, and open into the oral cavity with a separate sublingual papilla. There are also numerous small sublingual ducts, known as ducts of Rivinus, which may join the submandibular duct or open separately into the floor of the mouth.
So now, let's take a closer look at the internal structure of the salivary glands. The acinar structures of the salivary gland is analogous to the arrangement of grapes on a vine. The grapes represent acini, each composed of about 5 to 7 acinar cells. The secretion of the acinar cells is released into the duct system, which is here represented by a vine. The vine extends from the acini to the oral cavity, where the salivary secretions are released into the oral cavity as saliva to aid in digestion. The connective tissue of the gland, capsule, and septa surrounds and divide the gland into separate lobules. So acini drain into intercalated duct, which then leads to the striated duct. Enterolobular ducts are present in between the lobes, and finally, it enters the excretory duct and drains into the oral cavity. There are also myoepithelial cells present around the acini, which help in squeezing the secretion out of the acinus following neural stimulation. So let's now focus more closely. The acinus is a blind sac composed of secretory cell.
The term acinus means berry or grape in Latin, which refers to the secretory unit of the salivary glands. The acini of salivary glands contain serous cells. Serous cells produce serous secretions, which is high in protein, whereas mucous cells produce mucous secretions, which is high in mucin, or it can produce mixed secretions. Intralobular ducts are of two types: interrelated ducts and striated ducts, which are also termed as secretory ducts. The intercalated duct cells contains a few secreted granules, some rough endoplasmic reticulum, mitochondria, and a rounder oval centrally placed nucleus. Then in the case of striated duct, the term striated refers to the light microscopic appearance of the basal cytoplasm that has a well-developed striations perpendicular to the base of the cells. So this appearance results from infoldings of the basal plasma membrane that produces cytoplasmic rows containing numerous mitochondria. Hence, it is termed as striated ducts.
So, looking at the ultrastructure, the mucous acid cells are elongated structure featuring peripheral compressed nuclei at the basal region due to high mucus production within the cytoplasm. The nucleus of the mucous cell is oval or flattened in the shape, located just above the basal plasma membrane, and the rough endoplasmic reticulum is limited to a narrow band of cytoplasm along the base and lateral borders of the cell. Golgi apparatus are dispersed in the same loci. The mucous cells contain numerous mesonogen granules, and many of these granules correlate to form large irregular masses that will ultimately discharge into the lumen of the acinar cells. The serous acini, apically the cytoplasm, is filled by proteinaceous secretory that is hymogen granules which have high amylase activity. The serous acini are composed by triangular-shaped cells and round nuclei component responsible for secreting a more aqueous secretion. The mucous acini produce thick viscous saliva which contains mucous polysaccharides and mucin, whereas a series of acini produces thin watery secretion composed of zymotion granules which contain more proteins.
Another feature constantly seen in the histologic appearance of salivary glands are the serous demilins. They are rather artifacts of the traditional fixation method. So in the first image, you can see the relationship between the mucous serous cells as observed in the electron microscope following rapid freezing method. So the serous cells extend from the basal lamina to the lumen of the sinus, and in the second image, the serous cells are shown to occupy the periphery of their sinus, and this gives the appearance of the so-called serous demilins. This feature is visible in the nutrient routine preparations using immersion fixation. So the swollen mucous cells, they are forced out of the serous cells, leaving small remnants of the cytoplasm between the mucous cells, thus giving the appearance of serous demilins, but it is rather just an artifact. Another important feature of salivary glands is its contractile nature, which is represented by the myoepithelial cells or the basket cells. These are contractile cells with numerous processes that embrace the basal aspect of the acinar secretory cells. They lie between the basal plasma membrane of the epithelial cells and the basal lamina of the epithelium. So, in this image, the light blue cells are the epithelial cells. Let's take an expanded look. The nucleus of the cell is often seen as a small round profile near the basement membrane. The contractile filaments stain with eosin, and they are sometimes recognized as a thin eosinophilic band adjacent to the basement membrane. There is a general correlation between the thickness of the myoepithelial cell processes and the viscosity of the secretory product. Let's take as a live example on mucous acini.
This is again a diagrammatic representation of the secretory end pieces as we just discussed serous and mucus. Serous produces more watery secretions and mucus produces a more mucinogenic secretion. The acinus then finally drains into the intercalated duct and then the striated duct. The intercalated ducts are the first or the most distal element of the intralobular duct system. The intercalated ducts are lined by a locuboidal epithelium. They drain the secretory end pieces, that is the acini. The striated ducts, also known as secretory salivary ducts, they are the most specialized of the salivary ducts and they carry out most of the ionic transport functions that occur along the route of the salivary from the acinar lumen to the oral cavity. They are lined by tall columnar epithelial cells with a distinctly eosinophilic cytoplasm and spherical centrally or eccentrically placed nuclei.
In relation to the iconic transport that occurs, sodium reabsorption and potassium secretion occur within the cells, which are affected by the changes in the levels of adrenal cortical steroid hormones, mainly aldosterone. Therefore, the striated duct is similar functionally and histologically to the cells of renal distal tubule. The portions between the lobules join the larger duct that then join the interlobar portions that are present between the lobes and within the main excretory duct, which then empty into the oral cavity. As the excretory ducts become larger, the epithelium lining of these ducts changes from simple columnar to pseudostratified or stratified to columnar epithelium at or near the entrance to the oral cavity. The main excretory ducts became lined with stratified squamous epithelium, which becomes continuous with the buccal epithelium. This is the diagram comparing the components of the saliva, that is the secretory unit of the salivary glands in the three major salivary glands, the parotid, submandibular, and sublingual. The four major parts of the saliva are the acinus, the intercalated duct, striated duct, and excretory duct. And the three columns on the right of the saliva compare the length of the different ducts in the three salivary glands. The red-colored cells of the sinus represent serous secreting cells, and the yellow-colored cells represents mucus secreting cells. The ratio of serous sectoring cells to mucus-secreting cells is depicted in the acini of the various glands. So, in the parotid gland, intercalated ducts are long and narrow. Straighted ducts are also long. Parotid gland have a 25% contribution to saliva. Some animal glands have shorter intercalated ducts as compared to the parotid gland, but the straighted ducts are consequently longer. Submandibular glands are responsible for the producing about 60% of the total saliva produced by the major salivary glands. Sublingual glands have inconspicuous intercalated duct as well as the serrated ducts are also very small, and it contributes to about 5% of the saliva produced by the major salivary glands.
So, this was about the general structure of the salivary gland and its histological perspective.
Surely our stomach and minds have been filled with your reports, Doc Kisha and Doc Kat. Thank you. We will be back after this advertisement.
For as long as you remember, you brush all your teeth diligently, twice a day, right? But 80% of your mouth bacteria aren't even on your teeth.
80%?
Shocking, isn't it? That's why you need Colgate Total. It fights bacteria on teeth, tongue, cheeks, and gums. So, 100% of your mouth surfaces gets protected every time you brush. Colgate Total for whole mouth health.
And we're back. We are currently celebrating World Oral Health this month. This is an important occasion for us dentists, so I want to wish everyone Happy World Oral Health.
Happy World Oral Health.
As our tribute to this celebration, we'll be delivering to you an important information. We all have gone through this process, and your kids too, young parents, are currently going through this process. The topic we will bring to you is tooth eruption and tooth shedding. First, let us talk about the eruption of teeth.
Eruption of teeth is the process by which developing teeth move through the jaw bones and overlying mucosa to emerge in their respective place within the oral cavity eventually. Now, humans are diphyodonts, which means we have two sets of teeth during our lifetime. The first set, the primary teeth, also called deciduous teeth or baby teeth, start erupting at around 6 months of age, and by about 6 years of age, the primary teeth fall out and are replaced by a set of permanent teeth that stays with you for the rest of your life. Tooth eruption occurs in 3 phases: the pre-eruptive, eruptive, and post-eruptive phase. The driving force behind the eruption of teeth is still unknown, but is thought to be due to a combination of a few factors, which include signals originating from the dental follicle, more commonly known as dental follicle theory, root formation and elongation, which could drive the tooth in order to acquire space within the jaw. This is known as root formation theory, and formation of PDL, which provides an occlusal force aiding an eruption, also called as periodontal ligament traction theory. Okay, let's look at all the stages one by one, starting with the pre-eruptive phase. In this phase, the tooth germs are growing within the jaw bones. As the jaw bones grow in length, width, and height, more space becomes available for the tooth germs to spread out and grow without affecting each other. Lengthening of the jaw bones allows the anterior tooth germs to move mesially or forward and the molar tooth germs to move distally or backward. At the same time, as the bone widens, the tooth germs move backally or outward. And as the height increases, the tooth germs move closer to the surface. That is, the mandibular tooth germs move upwards and the maxillary tooth germs move downwards. In this phase, movement of the tooth germ is achieved by 2 methods: bodily movements and eccentric growth. In bodily movement, there is a remodeling of the bony crypts to resorption of bony crypt wall in the direction that the tooth is moving. This is followed by depositing new bone on the opposite crypt wall, hence creating a path for the tooth germ. Eccentric growth is where a part of the tooth grows relatively faster than the rest of the tooth. Eccentric growth helps the crown of the tooth reorient itself as the jawbone keeps growing. Now, the position of the permanent tooth germs is also changing in relation to the primary tooth germs. At the beginning of the pre-eruptive phase, the successional tooth germs lie lingual to their primary predecessors with their occlusal surfaces on the same plane. And by the end of the pre-eruptive phase, the permanent anterior teeth end up lingual and apical to the primary anterior teeth, and the permanent premolars come to rest underneath the divergent roots of the primary molars. However, this change in position is more due to the movement of the primary tooth and growth of the jaws rather than the movement of the permanent tooth itself. Now, you'd think that without the primary predecessor, the permanent molars would be developing unhindered, but their location right near the ends of the jaw is a very cramped up space. And so, the permanent molar tooth germs in the maxilla grow with their crowns tilted distally, and those in the mandible have their crowns tilted mesially. Only when the jaw grows to a sufficient size can the permanent molars move into a more vertical position. Next, the tooth germs enter the eruptive phase or the pre-functional eruptive phase, which begins simultaneously with root formation. The tooth ascends through the bony crypt and the connective tissue and finally comes into contact with the oral epithelium. The reduced enamel epithelium over the tooth crown then proliferates along with the overlying oral epithelium to form a single membrane. And this epithelium is pierced by the tooth to finally enter the oral cavity. The fused epithelium lining the sides of the tooth is now called the functional or attachment epithelium. Through the rest of the eruptive phase, the tooth gradually rises into the oral cavity till it reaches the plane of functional occlusion. Now, several changes are happening in tissues surrounding the teeth that help in the eruptive phase. In the region above each tooth, a path called eruptive pathway is cleared through the bone and connective tissue. The reduced enamel epithelium covering the dental follicle secretes colony-stimulating factor 1 or CSF1 and transforming growth factor beta 1 or TGF beta 1 into the surrounding tissue. The CSF1 and TGF beta 1 attract tons of monocytes that then differentiate into osteoclasts. These osteoclasts eat away or resorb the part of the bony crypt overlying the tooth. Without the bony crypt, the dental follicular cells become continuous with the cells of the lamina propria of the overlying oral mucosa. The reduced enamel epithelium then goes on to secrete some enzymes that break down overlying the connective tissue, nerves, and blood vessels, forming an eruption pathway for the tooth. The lack of blood vessel and nerves helps in a relatively bloodless and painless eruption. Now, as the tooth erupts, the epithelial root sheath begins to proliferate and starts to form the root. At the same time, bundles of collagen fibers start appearing in the surrounding dental follicle. The collagen bundles get invaded by fibroblasts that lay down fibrous tissue and thickens the bundles to form the periodontal ligament or PDL. The first PDL fibers appear at the cervical area of the tooth root and radiate coronally to the alveolar process. As the tooth erupts, more PDL fibers appear along the length of the root and existing ones become more prominent. In addition to fibroblasts, PDL fibers contain a special type of fibroblast called the myofibroblast. Myofibroblasts are cells with contractile properties and are thought to speed along the eruption. Moreover, researchers have found that PDL fibers continuously attach and detach from the tooth as it erupts. It is thought that these dynamically changing PDL fibers play a role in stabilizing the tooth and help in the eruption process. Some changes also happen to the tissue below the teeth. Eruption of tooth leaves behind some space at the bottom of the bony crypt. This space gets filled up by fine bony trabeculae or bone with tiny gaps in its structure. The bony trabeculae, also called bony ladder, provides support to the apical tissues. At the end of the eruptive phase, this bony ladder is resorbed to give way for the developing root tip. Ultimately, bundles of PDL fibers are laid down at the apex extending from the root tip to the bony floor. Once the tooth reaches a plane of functional occlusion, the post-eruptive phase begins. It is a phase for checking to see if the teeth remain in the optimal position and correcting any abnormalities due to jaw growth and occlusal or interproximal wear. As the jaw height keeps increasing, new bone is deposited along the socket floor to maintain the height of the erupted tooth in the arch. Occlusal wear is compensated by cemental deposition around the apex, whereas interproximal wear, which is the wearing of the contact surface between the teeth, is compensated by a process called mesial or proximal shift. The mesial shift is brought upon by a combination of forces acting on the teeth. These include the anteriorly directed force generated by the teeth when they are in occlusion, the pressure exerted by transeptal fibers of the PDL to keep neighboring teeth in contact, and finally, the pressures exerted by the surrounding soft tissue like the tongue and cheeks. The post-eruptive phase continues as long as the tooth remains in the oral cavity. Alright, as a quick recap, eruption of teeth is the process by which developing teeth move through the jaw bones and overlying mucosa to emerge in their respective place within the oral cavity eventually. The first set, the primary teeth, also called deciduous teeth, start erupting at around 6 months of age. And by about 6 years of age, the primary teeth start to get replaced by a set of permanent ones that pretty much stick around for the rest of your life with proper care. The eruption process itself can be divided into 3 phases: pre-eruptive, eruptive, and post-eruptive phase. The pre-eruptive phase is a preparatory phase that occurs before root formation and positions the tooth germ for eruption within the jawbone, kind of like how an airplane is wheeled onto the runway before takeoff. The eruptive phase, also called the pre-functional eruptive phase, begins at the time of root formation and consists of movements that raise the tooth upwards from within the bones to a functional occlusal position within the oral cavity. The post-eruptive, also called functional eruptive phase, begins once the teeth are in occlusion and consists of movements that maintain the position of eruptive teeth as the jaw grows and compensates for any wearing of teeth. We have learned from the tooth eruption topic that the human dentition, like those of most mammals, consists of 2 generations. The first generation is known as the deciduous or primary dentition, and the second one as the permanent or secondary dentition. The necessity for 2 dentitions exists because infant jaws are small and the size and number of teeth they can support is limited. Since teeth, once formed, cannot increase in size, a second dentition, consisting of larger and more teeth, is required for the larger jaws of the adult. The physiologic process resulting in the elimination of the deciduous dentition is called shedding or exfoliation. Now let's talk about the mechanism of resorption in tooth shedding. The cells responsible for the removal of dental hard tissue are identical to osteoclasts and are called odontoclasts. Odontoclasts are similar to osteoclasts in that part from being multinucleated, it has numerous vacuoles and mitochondria, especially adjacent to the ruffled border. The clear zone peripheral to the ruffled border shows contractile proteins, actin and myosin. Odontoclast and osteoclast have similar origins in that they are derived from monocytes. Odontoclast preserve all dental tissues in a similar way like osteoclast preserve bone. Hydrogen ions released from the ruffled border dissolve the inorganic portion and liberated lysosomal enzymes degrade the organic component. Generally, causative factors in shedding are pressure exerted by growing permanent successor tooth germ and increased masticatory forces. Pattern of shedding is different for the anterior teeth and posterior teeth. For all deciduous anterior teeth, resorption is initiated at the lingual side of the tooth. With subsequent movement and relocation of the teeth in their growing jaws, the growing permanent tooth becomes directly below the deciduous one and the resorption becomes apical. Now for the posterior teeth. For deciduous molars, root resorption is initiated in the inner surface where the permanent premolars initially develop. Later, the premolars come to lie beneath the deciduous molars. Further resorption at the apices then occurs. Let's talk about some clinical considerations about tooth shedding. Our first case is remnants of deciduous teeth. Sometimes, parts of the roots of deciduous teeth are not in the path of erupting permanent teeth and may escape resorption. Such remnants, consisting of dentine and cementum, may remain embedded in the jaw for a considerable time. They are most frequently found in association with the permanent premolars, especially in the region of the lower second premolars. Progressive desorption of the root remnants and replacement by bone may cause the disappearance of this remnant. The second case is retained deciduous teeth. Deciduous teeth may be retained for a long time beyond their usual shedding schedule. Such teeth are usually without permanent successors, or their successors are impacted. Once a retained deciduous teeth has been identified, it should most often be extracted. This is particularly true when the permanent tooth has already erupted. The last case is the submerged deciduous teeth. Trauma may result in damage to either the dental follicle or the developing periodontal ligament. If this happens, eruption of the tooth ceases and it becomes ankylosed to the bone of the jaw. Because of continued eruption of neighboring teeth and the increased height of the alveolar bone, the ankylosed tooth may be either shortened or submerged in the alveolar bone. Submerged deciduous teeth prevent the eruption of their permanent successors or force them from their position. Submerged deciduous teeth should therefore be removed as soon as possible.
And that's what we gathered.
In our profound research,
In our concern for one another,
We can bring hope to each other.
Thank you very much and long live, folks!